All right, let's talk about shock. It's a huge topic for the NCLEX, right? But what about that one tricky type of shock where your patient can actually be warm, even flushed, but is secretly circling the drain? Yep, today we are diving deep into distributive shock. You absolutely have to know this stuff, not just for your exam, but for your first day on the floor.
So, here's our game plan. We'll start with the basics, what distributive shock even is. Then we'll get into the 4 major types you'll see. After that, we'll talk about what your patient looks like and what you need to do first. And of course, we'll wrap it all up with a super high-yield NCLEX review and a quick case study to see if you've got it down. Let's do this. First things first, what in the world is distributive shock? If you can really grasp this core idea, everything else we talk about today is going to click into place.
Okay, so the official definition throws around some big words: widespread vasodilation and relative hypovolemia. Let's break that down. Widespread vasodilation just means the blood vessels get super wide and floppy. And relative hypovolemia, that's the key. It means you haven't actually lost any blood from your body, but because your blood vessels, the container, got so huge, there isn't enough blood volume to fill them up and create pressure.
I love this quote because it just says it all, doesn't it? The fluid is still in the body, but it's not doing its job. It's just hanging out, pooled in those big, baggy vessels, instead of getting to your brain, your kidneys, and your heart. It's a distribution problem, which is exactly why we call it distributive shock. So let's connect that to the actual pathophysiology. When the vessels lose their tone, their squeeze, what we call systemic vascular resistance, or SVR, just tanks. It plummets. And to make things even worse, the tiny capillaries start to get leaky, allowing fluid to ooze out into the tissues. This makes that relative hypovolemia even more of a problem. Okay, get your mental highlighter out for this one. This is a classic NCLEX phrase. Because all that blood is pooled in those dilated vessels right under the skin, the patient often feels warm and looks flushed, all while their blood pressure is dangerously low. If you see warm shock or a warm, flushed skin with hypotension on an exam, your brain needs to immediately scream distributive shock. So we know the main problem is massive vasodilation, but now we need to ask, what causes it? There are 4 major triggers, and you better believe the NCLEX loves to test you on the differences between them. Here are the 4 main culprits. You've got septic shock, which is caused by a massive infection. Anaphylactic shock, from a crazy allergic reaction. Neurogenic shock, usually from a spinal cord injury. And a rarer one, adrenal crisis, from a lack of cortisol. And see that alert? Don't forget it. Sepsis is by far the most common cause you're going to see in the real world. And each one has its own little story. For sepsis, bacterial toxins trigger something called a cytokine storm. It's like the body's immune system goes completely haywire. For anaphylaxis, it's a massive release of histamine that makes the vessels leaky and wide. With neurogenic shock, an injury high up on the spinal cord just knocks out the nerve signals that tell the vessels to stay tight. And in adrenal crisis, without cortisol, the vessels just lose their ability to maintain any tone at all. Okay, stop and burn this into your brain. This is pure NCLEX gold. In pretty much every other kind of shock, when the blood pressure drops, the heart rate speeds up to try and compensate. But not here. In neurogenic shock, you get this totally weird, paradoxical combination: a low blood pressure and a slow heart rate. It's the classic giveaway sign.
All right, so we know the theory, we know the why. But now let's talk about what we're actually going to see. What does our patient look like? What are those key findings you have to be able to spot from across the room?
You really have 2 different pictures depending on when you catch it. In the early or compensated stage, you'll see that classic presentation: warm, flushed skin, low blood pressure, and a fast heart rate. Unless, of course, it's neurogenic. But if things don't get better, the body gives up. In that late, decompensated phase, the patient becomes cool, pale, and clammy as the body desperately tries to shunt blood away from the skin to the vital organs.
And here is another absolutely critical point. Long before the vital signs completely crash, the brain starts to feel it. That lack of good blood flow, it makes people anxious, restless, or confused. A change in mental status can be your very first sign that your patient is tipping over into shock. Never, ever ignore it. So you see the signs. You recognize that your patient is in trouble. Now what? This is all about priorities. In shock, what you do and the order you do it in is everything. It's all about circulation. The very first thing we have to do is try to fill up that massive empty space in the vessels. That means fluids, 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 usually big bags of normal saline or lactated ringers. It's only after we've tried to fill the tank that we can think about squeezing the tank with vasopressor drugs. Always remember that order: fluids first, then pressors.
Now, while fluids are the answer for pretty much everyone, each type has its own special treatment. For sepsis, you've got to get those antibiotics on board fast. For neurogenic, you might need atropine to fix the bradycardia. For adrenal crisis, you have to give them the cortisol they're missing with IV hydrocortisone. And for anaphylaxis, I cannot stress this enough, the absolute #1, do it before anything else priority is giving epinephrine intramuscularly. It's a lifesaver. And your job is far from over. You're going to be watching their mean arterial pressure, or MAP, like a hawk, aiming to keep it at 65 or higher. You'll also be watching their urine output very closely. Why? Well, if the kidneys are making urine, it means they're getting enough blood flow, which is a fantastic sign that all the other vital organs are too. Okay, take a breath. We have flown through a ton of information, so now let's lock it all in. This is where we pull out the absolute highest yield facts that you have to know for your exam. This little chart right here is your best friend for exam questions that ask you to tell the difference between shock types. Just look at how much distributive shock stands out. It's the only one with a super low SVR, and it's the only one that starts out with that warm skin. Those are the dead giveaways.
All right, here's your rapid fire review. Ready? The defining problem is low SVR. See warm and hypotensive? Think distributive. See bradycardia and hypotensive? Scream neurogenic. For anaphylaxis, what's first? Epinephrine. And what's our MAP goal? At least 65. Got it? Good.
Okay, you've sat through the lecture. Now it's time for the pop quiz. Let's see if you can apply all this knowledge to a real-life NCLEX style scenario. Read the info on the next slide and start thinking like a nurse. So you get a patient who took a big fall. Right away, you're thinking potential spinal cord injury. You look at the monitor. Blood pressure is 82/46, heart rate is only 54, and when you touch them, their skin is warm and dry. The alarm bells should be going off in your head right now. What's going on here? And more importantly, what are you going to do first? Think it through. A, B, C's. What is the biggest, most immediate threat to this patient's life? What's your #1 move?
If you said stabilize circulation, you are 100% correct. This patient is screaming neurogenic shock. Your top priority is to get IV access and start pumping in fluids to fill up those vessels. You should also be grabbing the phone to get orders for vasopressors to add some squeeze and maybe some atropine to nudge that heart rate up. Your goal is simple: restore perfusion and save their life. And that is exactly how you'll use this knowledge. You can do this.